Good evening, everyone. So, this is Dr. Ajay Aggarwal, and today I am going to present a case of hysteroscopic resection of isthmocele. As shown in this video, this patient was posted for IVF for embryo transfer, but because of the fluid collection in the isthmocele area, which was going up in the cavity, the hysteroscopic isthmocele correction was planned because the residual myometrial thickness was 6 millimeter. So here what we intend to do in this surgery is to make the slope between the isthmocele and the adjacent cervical tissue, cervical canal, more soft, less angulated, and the base of the isthmocele, as you can see here in this video, is being resected so that the fluid which is getting collected here, the blood which is collected here in this base, you can see here it is deep inside, so this slope is being made soft so that the fluid stops getting collected here and comes out of the cervix easily, and that will help in no collection of blood in this part of isthmocele. So here you can see, you can notice very slow and gentle movement of the resectoscope. The resectoscope that I'm using is bipolar resectoscope, 22 French size, and what I'm doing is there are three things that I'm doing. One is I am taking out the entire endometrial tissue which is there in the isthmocele area. Second thing, the depth of the isthmocele is being resected. Third thing, the slope of the isthmocele is made more soft. So these three things are done in the hysteroscopic correction of isthmocele. So you can keep watching the video and I will keep mentioning the key points in hysteroscopic correction of isthmocele as and when required. Now here you can see this is the caudal end of the isthmocele towards the external os, which is resected to attain a nice slope. Then we go up towards the cranial end of the isthmocele, and here again, if at all we find that the angle between the isthmocele and the upper uterine cavity is also more angulated, then we can resect it and make it soft. Meanwhile, main aim was either to ablate the tissue in the isthmocele or to resect the tissue. So here you can see very small pieces of tissue is being resected with a very nice slow movement of the resectoscope. Another technique of isthmocele correction is by laparoscopy. It is done when the residual myometrial thickness is less than 3 millimeter, and because if you try to correct that isthmocele, which is also called the severe isthmocele, then one thing is chances of perforation will be more if you go by hysteroscopy approach. Second thing, the strengthening of the scar won't be possible by hysteroscopy, which is possible by laparoscopy route. But here in this case, because the residual myometrial thickness is quite good, which is 6 millimeter, and the size of the isthmocele was almost 50% of the thickness, so that's why we opted for this route of isthmocele correction by hysteroscopy. In studies, it has been shown to be having similar success rate compared to laparoscopy if residual myometrial thickness is more than 3 millimeter. Symptom wise, pregnancy wise, so results are same. Now here we again come out of the isthmocele in the cervical canal, and we see that can we have a look at the depth of the isthmocele. If not, then we make it the angle more soft. Now here there is a very small bleeder which came at the time of resection. So with the help of resectoscope, we can do point coagulation of the bleeders. So here you go very slow, identify the bleeder and use coagulation current and burn the bleeder. So bleeder can be taken care of with resectoscope using coagulation current. Now here again there is one more bleeder. You can see very small piece of the tissue is excised, and then we go in. Once it is out, notice backhand movement as well. This is the backhand movement. Then there is a bleeder here. We can see a very small vessel which is coagulated. Then we come out. Now we can see that when we are going in, we can see the base of the isthmocele as well. So that means the bank is excised nicely, and now the chances of fluid getting accumulated in the isthmocele and not coming out is very less. Why? Because the bank is smooth. The margin is very smooth. So we come out and we can see that our entire surgery is complete. This is the last bleeder which is being taken care of. So thank you so much.